Good afternoon, everyone. I'm going to be talking about which anti-glaucoma medications to choose from the many options that are available. I have no financial interest to disclose. So medical therapy is the cornerstone of managing majority of our glaucoma patients today. And because of the advances in glaucoma therapeutics, the physician of today has a variety of anti-glaucoma medications to choose from for both initial and adjunct therapy. But with these great choices comes great responsibility. Responsibility to choose the right medication for the right patient to give the best results. Overall, we've got 6 contemporary classes of anti-glaucoma medications. The first 5 are topically used. The first 4 of the ones listed here are the ones that we commonly use today: prostaglandin analogs, beta blockers, alpha agonists, and carbonic anhydrase inhibitors. Anti-glaucoma drugs have been around for a long time. Since the 1800s, pilocarpine was the drug of choice to treat glaucoma. It was actually the only topical medication to treat glaucoma until the 1980s when timolol came along, and that has largely been changed now in the mid-1990s with the development of latanoprost, or actually prostaglandin analogs, that have replaced timolol as a first-line of treatment. And then since then, there has been several advances in the field where a lot of fixed combination drugs have come along, and more recently with the ROCK inhibitors that have actually acted on the trabecular meshwork outflow, as well as latanoprostene Bunode, which is a latanoprost plus a nitric oxide component. So a lot of advances has come along lately. The key strategy and our goal is to lower IOP to a desirable level using the least amount of medication possible, with an ultimate goal to maintain visual function, quality of life at a sustainable cost. Now, when we talk about the choices everyone has available, we're assuming practitioners have access to all the contemporary classes I mentioned in the previous slide. But in the real world, things are very different, and it can be very complicated. Not all options are available either because of cost or because of obstacles to distribution. So when selecting an initial medical therapy for a glaucoma patient, it is important not only to consider drug properties such as mechanism of action, efficacy, safety, and cost, but also to look into the relevant patient and disease characteristics, such as the clinical picture of the patient, the type of glaucoma, the stage of glaucoma, what is the rate of progression, the highest IOP before treatment, as well as other risk factors. Systemic health is also very important. Any comorbidities, any cardiopulmonary risk factors, any contraindication to therapy, any allergies towards any medication. The ocular health, you need to look at the ocular surface disease, as well as any concomitant ocular comorbidities. Adherence to therapy, you need to make sure the patient can adhere to the regimen you prescribe. Can they tolerate the side effects? And of course, looking into quality of life, life expectancy. In the end, of course, before prescribing anything, you need to involve the patient in their care. You need to really check and give them an informed decision and make an informed decision on their medication. Obviously, you will choose between individual classes or combination therapy. You'll choose between preservative drops or non-preservative drops, generic or branded. There's no standard medical regimen that is appropriate for every patient currently, but however, there's an algorithm that possibly we can go by in the average patient. Usually we start with a monotherapy, as Dr. Omnia mentioned. Usually it would be a prostaglandin analog. And then if that is not tolerated, the only exception to the rule to that, if a patient comes with very advanced disease, very high pressures, then maybe you would beat the gun and go for a fixed combination to start off with. But majority of the time, it's a monotherapy with a prostaglandin if there's no contraindications. If the patient does not tolerate the medication or the pressure reduction is not effective on the IOP, then you would switch monotherapy. If the drug is well tolerated and it's effective on the pressure, but the target IOP is not reached, then the option here is to add a second drug. And when you think of adding a drug, there are 3 options. Either you add a single agent, or you add a fixed combination other than the initial drug that you've added, so you've got 3 drops now instead of 1. And then option 3 would be to switch to a fixed combination that includes the first drug. So if you started off with a prostaglandin, you might want to give a fixed combination of prostaglandin beta blocker. However, at any stage of this algorithm, you will need to reevaluate the patient disease relevant characteristics, as we mentioned earlier, and you need to monitor for side effects as well as disease progression. So we'll go drug by drug. So prostaglandin analogs, they're the most often selected first line. They're highly efficacious. They're convenient to use with a once-a-day dosing, and they don't have many systemic side effects. And because they actually reduce pressure for more than 24 hours, they're least affected by non-compliance. So they have a little bit of a leeway there. They're independent of episcleral venous pressure because they increase uveoscleral outflow, so they're beneficial in patients with secondary glaucomas due to high EVP. They decrease pressure during the diurnal cycle, and studies have shown that the best adjunct to a prostaglandin would be a carbonic anhydrase inhibitor in terms of IOP efficacy of reduction. It may also enhance perfusion pressure because it only lowers IOP but doesn't really affect BP or cardiac output. So that's the benefit there. However, if you have a young patient or a patient with unilateral disease, maybe a prostaglandin won't be the best drug because you don't want to have an asymmetric cosmetic ocular side effect, such as hypertrichosis or ocular pigmentation. It's really controversial whether to use it in inflammatory glaucoma, but it's definitely not the first line. You should caution the use of prostaglandins with patients with known risk factors for CME or who have previous outbreaks of herpetic eye disease. It's contraindicated to use it in pregnancy as it is a class C drug. It can cause premature labor. Preservative-free options, you have tafloprost in the form of Zioptan, and you have an alternative to BAK, where it's Travatan Z, the Sofzia, which is even more gentler on the eye. Beta blockers are still a popular glaucoma medication. They work well. They're actually a component of many fixed combination therapies, so the likelihood of you bumping into a beta blocker is high to give a patient. It's safe in children, and it's actually beneficial in heart failure. It reduces mortality. It can be used after consultation with a practitioner in terms of the heart failure and any patient with already an existing oral beta blocker. But you need to keep in mind that if you do use topical beta blockers over oral beta blockers, there's a chance that there's decreased effectivity there and there's more degree of bradycardia. You'll avoid beta blockers in patients that are susceptible to cardiovascular and respiratory conditions such as COPD, asthma, emphysema, asymptomatic bradycardia plus a heart block, symptomatic bradycardia, severe hypertension, hypotension. So it's useful to measure the BP and the resting heart rate of any patient before starting a beta blocker. You avoid it in myasthenia gravis as it can aggravate the condition, and you caution its use in advanced diabetes or insulin-dependent diabetes, but not really so much in just regular run-of-the-mill diabetes. It has no IOP-lowering effect at night, so there's actually a potential negative effect on the perfusion pressure and risk of progression. It does not work well in uveitic eyes. If you do want to select a selective, cardioselective beta blocker, you would go for betaxolol if you really have to choose a beta blocker. And the preservative-free version of timolol is Ocudose preservative-free. Alpha agonists, so they're aqueous suppressants. They also can increase uveoscleral outflow. It's not proven that it has a neuroprotective effect. Its use in pregnancy is a class B. So if you have to choose an anti-glaucoma medication during pregnancy, first and second trimester, if you really have to do that, then probably your best bet would be an alpha agonist. However, in 10 to 20% of patients, you will need to discontinue the drug because of ocular allergy. So that's a big thing there, and that can even occur many years after starting the drop. The other thing, the downside, is the multiple dosing. So if you use it as monotherapy, you'd have to use it at TID dosing. If you have it at polydrug or polytherapy, then you can go by with a BID dosing. It's contraindicated in children less than 2 because of CNS depression and lactating mothers as well. The concurrent use of antidepressants is also a contraindication, and you should caution the use of it in ischemic heart disease or MI. It also, like beta blockers, have no IOP-lowering effect at night, and they have a potential for a negative effect on perfusion pressure and risk of progression. Alternate to BAK, one of the drugs has an alternate there, which is purite as a preservative in the form of alpha-GAN-P. So carbonic anhydrase inhibitors, they're quite efficacious. Their efficacy differs whether you're giving it topically or orally. It's more efficacious orally. There's no effect on any cardiovascular pulmonary function, so that's a plus. Recent evidence has shown that there's a wider use in sulfa allergic patients. They actually looked at patients and said that there was absence of cross-reactivity between the sulfa antibiotics and the sulfa non-antibiotics. So probably you can go by with using it in those cases. It works well in uveitic glaucoma. It's tolerated in children and nursing mothers. And as we mentioned earlier, it's a best additive to prostaglandin analogs, as well as enhancing perfusion pressure, as we mentioned with prostaglandins. You'd avoid topical carbonic anhydrase inhibitors in a compromised corneal endothelium. Similar to alpha agonists, it's multiple dosing if it's used as monotherapy and BID as polytherapy. For oral medications, because of their fast onset of action, it would be used more in acute glaucoma, as we know, like an acute angle closure, for instance, and you would avoid it, let's say, for long-term use. Patients with hepatic disease, renal disease, sickle cell, G6PD, or any electrolyte derangement would not be a good idea to use carbonic anhydrase inhibitor. Now, 30% of patients require adjunctive treatment within 1 year of starting a prostaglandin analog. So we need to discuss about adjunctive therapy and the options we have here. So as I mentioned earlier, you could either add a single therapy, you could add a fixed combination, or a non-fixed polydrug regimen where you have like multiple single agents. Now the fixed drug regimens over the polydrug regimens have some advantages. You're using minimum number of bottles with minimum dosing frequency, so you have the improved compliance and convenience there. You have less exposure to preservatives, and you avoid potential washout and potential lower cost. However, you need to remember that whenever you add a drug, there's the law of diminishing returns. So the more you add, the less you get out of your addition. And you need to remember that with fixed combinations, if a patient develops an allergy, you don't really know from which component of that fixed drug are they developing the allergy from. So when we talk about generic versus branded, they're the same in terms of quality and quantity of the composition of the active ingredient. Where they differ is in their adjuvants and or the stability agents within them that causes differences in their viscosity, surface tension, and pH, and obviously that would alter efficacy and safety. So my take-home message today is that glaucoma care is more of an art than a science. You can't really treat all glaucoma patients the same way. You need to tailor the regimen according to your patient and the disease characteristics. And every day brings new choices. So as we see now, there are drugs that increase trabecular meshwork outflow. And if we use it in conjunction with patients that have that you can give drugs for aqueous suppressants or increase uveoscleral outflow, you have a synergistic or complementary actions there. There's also the thing about non-hypotensive drugs, so we don't really look at IOP lowering, but on neuroprotection instead. So the choices are really variable, and my advice is that we need to choose wisely, whatever choices. The more the choices, the more we have to be wise about choosing them. Thank you very much.